Well, good morning. It's nearly 9, and I think I welcome you all to the second IC this morning. And we continue with glaucoma, and we continue with glaucoma in children. And we are going a little off tangent from the clinical and the surgical thing, and we're going to talk a bit about diagnostics. So today we're going to talk about ultrasound biomicroscopy in childhood glaucoma. And I think it has really changed the paradigm, and it has taken our understanding of childhood glaucoma and our management decisions to another level. So I'm very happy to have on the course Professor Pandav, Dr. Gaurav, Dr. Faisal, Dr. Sirisha. And I would invite Professor Pandav to please give the opening introductory remarks.
I think Dr. Sushmita has already introduced actually the topic. So what I'll do is I'll just introduce the technology, because we are talking a lot about UBM in this. So I'll just give you a little bit of recapitulation about the technology, what the UBM basically is. So this helps us acquire and view real-time high-resolution images of the anterior segment under magnification, and that allows us to determine the relationship between different ocular structure in the anterior segment, especially related to the angle. And this is a non-invasive imaging modality and produces high quality images, two-dimensional of course, but I think that's clinically is very useful. Typically you have about 50 megahertz frequency probe, but it could be higher or lower. More often we are getting 30 megahertz these days, but I think for good resolution you have to have 50 megahertz probe, and which gives you a the later resolution about 50 microns and the axial about 25 microns. But as you go higher in frequency, the tissue penetration gets less. So that's a kind of trade-off. The principle is simple, is like any other ultrasound, is basically a pulse ecosystem. So you send some echo pulses at certain frequency into the tissue, and the echoes which are returning, you just capture them, and because they're timed. So from the the time of the sending to receiving, that gives you the distance or location of the or the object which is sending reflecting the sounds, and also how much sound received, that gives the intensity. So basically two parameters, the time and the intensity, and then you have those multiple echoes coming back, and then you reconstruct it to dimensional image because they're like a B scan. So the principle remains the same. So to get a lot of echoes, this is oscillating kind of a transducer, so that you can cover a certain area or certain angle in the tissue. The important thing is that you need to have a very good tissue probe interface, and because if that's not taken care, then a lot of sound will get reflected off the interface itself, and then the image quality will be poor. So when you're doing an ultrasound, for UBM you will invariably need a water bath technique, where so that the reflections from the interface are minimized. And as the sound wave travels to tissue depth, you can create these images, and changes in the tissue density interface and the interface are shown in various degrees of brightness. So this is how you reconstruct that image. So this is like typically like any other ultrasound scan basically, because the high frequency transducer, so it produces high resolution images, and of course the depth of penetration, I said, could be a limitation. There are a number of machines are now available. Useful like this machine is no more available now actually, but I think in our institution some of the best ultrasound images that we have captured were using this machine, but now it is not there. And as we will be discussing more, UBM is a very useful tool for studying anterior segment of the eye, especially in children, because a lot of pediatric glaucoma, you have angle anomalies, and cornea is not clear, and you don't actually you want to see what is happening behind the surface that you are seeing. And there, as Dr. Sushmita also remarked, UBM has actually is one investigation which has changed dramatically the understanding about the diseases, and we are actually getting now more and more insights into what's happening behind the surface. So the more is going to come in this in the instruction course, and you will see all the details in how we use this technology for benefit of the kids. Thank you very much, Sushmita, for bringing me here, and thank you, everyone.
Thank you, sir. So, course outline, either? So, in the next couple of minutes, we'll just go through the outline of the course and what you will expect as soon as I get the slides here. No? Yeah? Okay. So this course is really about the mystery of beneath the ocean of congenital glaucoma, and believe me, there's so much underneath that same corneal opacity and high pressure that you see. So these are my co-instructors. I'm very thankful to all of them. Professor Pandav, head of glaucoma service. Gaurav was with us, and now I'm sure you'll be hearing more about him. He started his own hospital in Bhatinda, which we're very proud of, but he's done his fellowship with us. Dr. Faisal is an associate professor with us in our department, and Dr. Sirisha needs no introduction, head of glaucoma at LV Prasad, and a co-conspirator for taking care of children as much as we can. So Dr. Pandav has already told us the background of the UBM. And in children, for opaque corneas and structures behind the iris and ciliary body area, when you need to examine them, this really is the only investigation tool that you would have. And it's a condition which is difficult to treat, often presents with a cloudy cornea, and precludes the usual clinical examination of an eye which we do. So we'll go on to the next, and can we have the next, please? Next to the range. Next, Dr. Gaurav ka hai na? Udhar hoga. So we'll go on to first setting up the machine and doing the procedure. And the chronology is going to be, once we've done it, what is it that we see and how do we interpret what we see? And then we'll go on to, once we've interpreted what we see, what does it mean? And then we'll go on to, once we understand what we see and what it means, how does it change management? So that's the flow. I hope they can get the thing, yeah? You're there? Idhar hai? Okay, so Dr. Gaurav will talk about the procedure itself and how to do it.
A very good morning to all. At the outset, I would like to thank AIOC and Dr. Sushmita, Dr. Pandav, and whole glaucoma team PGI for giving me this opportunity to speak on this topic. So I'll be discussing in my talk from very basic about the UBM, how to set up the machine, how to do patient preparation, how to do probe preparation, and what are the various techniques to do UBM. So I hope that after attending this session, everyone will be able to do UBM on their own who have this machine. So it will be a video-based session. So first, setting up the machine. So machine has various parts. It has printer, a monitor, a console, a probe, and UPS and CPU. So first, we need to turn on the UPS, then the CPU, then we start the console. When the console is on, here we can see the console is on. So the probe is of 50 megahertz, so this machine comes with B-scan also, so 50 megahertz has to be selected. Then patient entry is done. So patient details are very important and they has to be saved very properly because UBM is routinely done in children on follow-up basis. So to study the follow-up also, we need to have the right data. Then here, the machine will appear like this. So here we need to select the eye properly. So here we can see the option is there, so we need to select the right eye or the left eye. And we can interchange these eyes in between if we need to see the other eye during examination. So once we are ready, we press the foot pedal and then the UBM will start. So this will appear like this. So this was setting the machine. Then we will be coming to the probe preparation, how to do the UBM procedure. So things required for doing the procedure are distilled water, viscoelastic, clear scan or scleral shell, a speculum and a saline. So we need to have these things ready, because in children the procedure is being done in GA in non-cooperative patients, so we need to have all things ready. So the probe appears like this. So here we need to see, this is the mark. Like on every ultrasound probe also this mark is there. So this is very important to understand the orientation of the structures. So wherever the mark we align, that part is appear on the right side of the screen. So this is very important to understand the orientation of the images which we will be getting during the procedure. So first I'll be demonstrating the scleral shell technique. So it is the most commonest of all, which is done routinely. So first we open this cover of the probe. Then there is a space. We need to fill this with distilled water. Care should be taken that not normal saline, RL or any other fluid should not be used, because those ions will stick to the probe and it will affect the transducer. So it has to be filled completely with the distilled water. Here we can see the inside, what we can see the structure, this is the transducer. Then it is covered with this clear cover, and here we can see the movement of the transducer. So when this transducer moves, here we can see with the movement of the transducer, the images will appear like this. It means the probe is ready to use. So this procedure is done in supine position. Patient lies comfortably. First parakin is inserted topically. Then this is the cup, which is fixed in the palpebral aperture. The cups comes in various sizes, so care should be taken. Like in children, if the palpebral aperture is small, we need to choose a smaller size, and if it is large, we need to choose a larger size. Then this cup is also filled with sterile water. It is more of a coupling media, and it is an immersion based technique. Then here we can, this patient I am demonstrating is a post-trap patient. So to understand the anatomy very well, so here we can see the mark is aligned inferiorly. Okay, so on the images you can see when the mark is aligned inferiorly to superior, we have the bleb. So here we can see the PI and a scarred bleb. So this is the image. So for ideal good image quality, the images should come between those lines which were coming, and we can save these images also. So now I'll be demonstrating the clear scan technique. So it is very useful technique for children, and this technique can be used in supine as well as sitting position also. So this is the clear scan cup. This is very delicate. The difference in both the technique is the cost. This is a disposable cup, but it can be used multiple times. Company suggests for single use. It is very delicate. It is filled with distilled water. Care should be taken not to touch the film, because if we will touch it, then it might rupture. So it is completely filled like this. Then we fix the probe. There no need to apply the cover in between. So we fix the probe completely like this. Here is a button. This button is pressed to insert it. It should be inserted completely tightly to appear like a bullet, so that there is no air in between. Now you can see we can tilt it anyhow. It is now like a normal ultrasound probe. So we can use it anyhow, even it like this also. So you can see the movement of the transducer and the images come. The images come of really good quality in this, because there is no in between any media. So for this we need to apply a speculum in patient's eyes. This technique is very useful in children, because children sometimes aperture is small, large, so they are very comfortable with it. Then we need to apply viscoelastic after putting paracaine, because it will directly contact the cornea, so as not to create any abrasions or anything. So here also we can see we will directly have a contact of this thing. And this similar thing we will be demonstrating, that inferiorly we are keeping it, the same patient. So you can see the same thing, that on the left side we are seeing the PI and the bleb area. So the procedure is different, but the images qualities are similar. So what are the special consideration for children? Because procedure has to be done for under GA for small children, because children are not cooperative many a times. So it can be clubbed with examination under anesthesia, so as not to give anesthesia again and again. The sizing of scleral shell has to be selected appropriate for palpebral aperture size, and clear scan technique is more useful in children because children are more comfortable with this. So the take-home message for today is doing UBM is an art, and every glaucoma specialist should master it, as UBM can unravel many mysteries underneath the cornea. As in childhood glaucomas, the corneas are mostly not very clear. So to find what is beneath it, a UBM can be a really good tool. So I would like to acknowledge Dr. Pandav, Dr. Sushmita, Dr. Sagarika, and whole glaucoma team, and most importantly my patient who cooperated for the and gave consent for the video. Thank you so much for patient listening.
Thank you, Gaurav. That was well put. We'll take questions at the end, if any. I now invite Dr. Faisal. And once we've done it, the problem is to interpret what is it that you see. So he'll tell us what we see and how to interpret that.
So, very good morning, everybody, and I thank Professor Sushmita Madam for giving an opportunity. So, as
This is what happens when you have the same team with 3 ICs back to back. So I think this is Faisal's talk of the next session, the next IC. Actually, we could have the next one, but the chronology is actually to interpret what we see and then So in the meanwhile, we can take a question or two, if by the time he's setting up. Okay, I think we are good to go, right? Okay.
Yeah, sorry for interruptions. So, as the pediatric glaucoma is a serious cause of childhood blindness worldwide, and is often poses a diagnostic and therapeutic challenge to the ophthalmologist, and PCG is the most common one. So UBM is a high-resolution ultrasound technique that allows to non-invasive in vivo imaging of structural details of the anterior ocular segment at equal to nearly a resolution of light microscopic that you usually see in histopathological examinations. So it's useful for assessing the morphology and understanding the various pathology of the anterior segment in the glaucoma. It helps in examination various, as already told the previous speaker, it helps for examination of the anterior segment in an obscured cornea or any structure behind the iris. It has a role in diagnosis in challenging cases and help in prognosis of the cases also. So normally, normal cornea usually look like this. This multi-layered structure and outer hyperechoic layer that contains epithelium. The stroma is more of minimally echoic than the inner one. The desmet is the hyperechoic. So in anterior segment, the first the Schwalbe's line, that is the junction of translucent cornea and opaque sclera. The second picture I took from this article, She's et al. Published in PLOS 1 2020. They had used it to 80 megahertz probe. So they could identify even Schlemm's canal in a better way, and they could identify the thickness of the trabecular meshwork also. So in the The next one is the identification of the most prominent landmark, that is the scleral spur. Scleral spur is the junction. It is the anterior limit of the junction of your sclera and the ciliary body. So that is the constant marking. After identifying scleral spur, then you can assess the trabecular irido angles. If possible, there is iris thickness, because PCG there is a changes in the iris thickness that I will be coming to later on. And this is the ciliary process. This is the anterior chamber depth, peripheral anterior chamber depth. This is the corneal thickness, the periphery. This is the posterior chamber. So next, the lens is usually a spindle-shaped structure. Here you could see the spindle-shaped lens, though there is a cataract, and this is the zonules. This is the ciliary body, and this is the ciliary sulcus, that is space between the ciliary process and the posterior part of the iris. So what are the changes in PCG and compared to normal? In PCG, from the cornea, there will be loosening of the epithelial layer, that is less echoic, and there is a corneal edema, hence there is a thickening. In the lower part picture, there is the corneal thickness measure is more than 1500, more than 1.7 millimeter. If there is a defect, that is the descemet tear, you can well appreciate it in the UBM. Initially, there is a defect in the descemet layer, and the margins are delineated as excavations. So this will be corresponding to your descemet tear. So what are the changes in primary congenital glaucoma? In the PCG, there is a widening of the trabecular irido angle. There is a thinning of the iris, and there is like this schematic diagram shows that there is shortening of the Schlemm's canal, and there is different type of that is abnormal iris insertion that I will be later on. And Dr. Shi and et al., they could appreciate even the membrane also, that is the membrane that usually demonstrates histopathologically in the primary congenital glaucoma. They used actually an 80 megahertz probe. So they graded the angle, depends on the insertion of the iris and ciliary body. The severe dysgenesis means both the iris and ciliary process inserted anterior to the scleral spur. The moderate one is the iris inserted at the level of the scleral spur, and the mild one, that is the posterior to the both iris and ciliary body inserted posterior to the scleral spur. What are the importance of this grading? They found that if there is a severe dysgenesis, one go better for a filtration procedure rather than going like canal-based procedure like microcatheter assisted goniotomy. They found that for the severe dysgenesis patient perform poor after a micro-assisted trabeculotomy. And also, if there is a total dysgenesis or severe dysgenesis, there is an absence of P1 G1 enzymatic activity. In case of milder one, at least there have a 60% preserved CYP-B1 enzymatic activity also. So just quickly go through some of these structures, like this is the case of Peters anomaly. There is a defect, central defect in the descemet along the defect in the stroma. That can be have different grades. That's here is a minimal, here is somewhat moderate. Sometimes the iris and lens can adhere to this structure. This is a case of Peters anomaly. Microspherophia, as this is the normal contour of the lens, should be the normal contour of the lens. Here the lens is more globular. One you track, this is the posterior extent of the posterior capsule. There is a globular spherical lens that's suggestive of microspherophia. This is here you can see there is adhesion or tending of the peripheral iris along the peripheral cornea, and this is a case of Axon-Rieger-Field anomaly. Congenital rubella, ma'am did extensive work on this. This is a poor prognosis case. UBM helped to diagnose the congenital cataract, which is also part of congenital rubella syndrome. If we miss the cataract, the patient will visual rehabilitation will be difficult. So you need to diagnose it before your surgery. Even we can diagnose it before even doing the primary procedure. And this in this picture you could see there is hypoechoic area that is suggestive of fluid between the anterior and posterior stroma. This is a picture of a case of acute eye drop. The last one is the congenital aphakia. There is one should not miss this case, but there is a single chamber. There is no structure behind the visible. There is more of a single chamber. So pre-operative diagnosis is very important. If you miss pre-operatively and go on for surgery, the eye will be invariably going for a I6. So, in conclusion, UBM is a good tool for detection of anterior segment changes in congenital glaucoma. And identifying the scleral spur is the key, which is UBM is helpful especially in cases of opaque cornea or cases with borderline clinical finding, helpful for grading of the PCG and other congenital anomalies, even can prognosticate the disease. I thanks all the teams and ma'am. I took all the majority of the picture from ma'am's library, and Dr. Ashok and Dr. Sagar and Dr. Gaurav for giving pictures for these presentations.
Thank you, Faisal, for bringing that up. I now invite Dr. Sirisha to correlate whatever we see to what the underlying disease is.
Connected देना बोल.
Yeah.
हम इसको एक्सटेंडेड कर देंगे इसमें.
क्या?
एक्सटेंडेड है. सेलेक्ट कर दिया आपने. फुल स्क्रीन कीजिए. हाँ शो डब्ल्यू करो. सेटिंग करना पड़ेगा आपका, क्योंकि आपको डिस्प्ले
इसके लिए तो पूछा ना.
मैम वो लैपटॉप आ रहा है आपको, जो सेटिंग है ना उसका जो प्रेजेंटेशन शो कर रहा है ना, तो वो नहीं आ रहा है. बाकी तो आपको आ रहा है, इसको बैक कीजिए, आपको आ जाएगा वहाँ पे सिस्टम पे.
अभी क्या करना है?
डिस्प्ले सेटिंग में जाइए. नेक्स्ट कर दूँ आपका सेटिंग करके. नेक्स्ट अभी करवा दूँ, इसके बाद आपको
ये लास्ट होगा ना.
So, meanwhile, we can take a question or two, a comment. Anybody would like to, about the procedure, about interpretation of what we see, and we'll go on to the findings. So, while they are setting it up, Dr. Faisal, who would be the child in which you would like to do a UBM? Let's start the discussion rolling. Can somebody give him a mic, please?
I think if you have machine any patient with opaque cornea,
Yeah.
actually we don't know what is the anatomic structural detail within the eye and ear segment, because there can be ectropy and uvea, there can be, what about the I already insertion of the iris level, that's also important for planning. If the iris is severely diseased, then goniotomy may not be workful for that patient, more for that more invasive surgeries.
Yeah, because they all look the same, but
Yeah.
the management could change with what they have. Yeah. Yes, Sirisha. Sure.
Yeah, sorry about that. So, Faisal has very beautifully shown, once you do the UBM, how to interpret it, right? So now we will look at what are the clinical correlations and how do we interpret the diseases. So congenital glaucoma is not very uncommon in our country, and we don't see a very clear cornea. So which means that majority of the time we see eyes with very, very hazy corneas, and sometimes we... क्या problem है? Sorry about that. So anyway, let him connect it. So we do see patients presenting with very severe corneal haze, which means that there's grade 4 or 5 corneal edema, and we do not see what is happening underneath. All we know is there's elevated intraocular pressure, there are large eyes, and we know that there is glaucoma. We have to go ahead and do the surgery. But until we operate and the cornea clears, we do not know what lies underneath. So while it is a mystery and we do not know what to expect, the prognosis obviously will depend upon what is there underneath. it is not necessary for you to operate and then come to a conclusion as to what the condition is. We should be able to diagnose it pre-operatively. And we also have to remember that not just primary glaucomas, several types of secondary developmental glaucomas also can present with corneal haze, sometimes partially, sometimes completely. So when you have an eye like this with a cloudy cornea, and that is sudden presentation of whiteness in the eye, the parents bring the child to the emergency, but we need to understand what is underlying this. Okay, is this an aniridia? Is this an iridocorneal adhesion? Is this something else? Those things, timer on kiya hai, nikal dijiye usko. Okay, so there is a very beautiful article that was published by Ken Nischel's group, which looked at clinicopathological correlation and also looked at what features were there on ultrasound biomicroscopy, and they correlated with the clinical diagnosis. What was very interesting was, of the group of patients that they had seen, close to about 38% of the eyes, the clinical diagnosis changed after the UBM, and majority of those where there was a difference in this clinical and the UBM diagnosis matched with histopathology, which means that you cannot have a better confirmation than that. So UBM is definitely necessary to make a diagnosis in most of the conditions. So it helps to establish diagnosis and also plan appropriate treatment. A couple of examples that I will show. A 1-month-old child presenting with hazy cornea, elevated IOP, enlarged corneal diameter, irregular anterior chamber depth. So if we partly see it and we know that there is some irregularity in the anterior chamber depth, we do not know what the condition is. UBM clearly shows that there are iridocorneal adhesions, there are multiple pockets, and most likely this is something that you're dealing with, congenital iris cyst. So similar kind of presentation that you see in a little older child, but the irregular anterior chamber depth is more of peripheral rather than central, and you see that there are iridocorneal adhesions and angle is completely closed. This child has Axenfeld-Rieger anomaly. So these two conditions that we just saw, who may have irregular anterior chamber depth with iridocorneal adhesions, but even before we could take the baby up for an examination under anesthesia or operate them, we will be able to understand the diagnosis prior and possibly prognosticate and plan your treatment better. This was a child who was a 4-month-old, again presented as congenital glaucoma. So everybody has enlarged corneal diameter, some of them have HABs striae, and when we did a UBM, there was no gap between the iris and the cornea. The entire iris was stuck to the cornea, and what you're seeing here posteriorly is the lens. So this patient has a if you on a cursory examination, it looks as if there's a deep anterior chamber. Deep anterior chamber, that's because the iris is stuck to the cornea. I think interpreting the structures, which Faisal just alluded to, is very, very important. And this patient actually had persistent pupillary membrane with pupillary block and secondary developmental glaucoma, required a pupilloplasty along with a trab and trab. And this child had deep anterior chamber after the surgery, cornea cleared, and intraocular pressures to a great extent were controlled. So it also helps to rule out diagnosis. So this was a baby referred again as congenital glaucoma for surgery. There was mild corneal haze in one eye, diagnosed as PCG and referred for surgery. The corneal diameters were increased. Right was little more than the left. But on examination, the child had a CD ratio of 0.2, intraocular pressures were 2. So here I don't think we are dealing with glaucoma. Sometimes you may be wrong because you may have low IOP, maybe because of corneal edema, but because the enlarged corneal diameter is accommodating for the raised intraocular pressure, you may not be able to record the IOP. Base scan showed attached retina, but the lens reflexes were slightly deviant from its normal position. This is the UBM that shows flat iris and a very, very concave iris in the contralateral eye. This baby had bilateral subluxated lenses. One of the visits, when we were waiting for the surgery and baby was coming in for a PAC checkup, the lens had displaced into the anterior chamber. So what was this condition? This condition, we did a genetic testing after that. It is a very clear congenital megalocornea with spirophakia. That can present with secondary glaucoma, and here the treatment is not to go and do a glaucoma surgery but to remove the lens. So it will help you to diagnose appropriately and do an appropriate treatment, because most often Arif Khan has very beautifully written in his articles that if you go and do a glaucoma surgery in these eyes, you will end up having an RD and lose the eye. Okay, so you should not touch these eyes. Sometimes you have unusual clinical presentation. This was a patient who had a post-operative extensive choroidal detachment, although this is deviating from congenital glaucoma. I thought I should show you this. This patient had choroidal detachment, but just see the CD there. You see those fibrillar material there. That was very, very unusual. This looked like an end-off. In fact, on the clinical, when the retina surgeon saw it, said, this looks very abnormal. I think this is we are dealing with a chronic endophthalmitis. But this patient had a CD with extensive inflammatory membranes. This patient required steroids, and after that it completely resolved. And you can see that everything became, as if nothing happened to this eye. So sometimes it also helps to interpret. This is again a picture not of congenital glaucoma, but we do deal with these cases. Young patient, elevated IOP, aphakic. In aphakics, to understand a pupillary block is extremely difficult. This patient actually had a pupillary block. You can see the peripheral tenting of the iris, but if you just look at the anterior chamber depth, it's quite deep. You will not be able to diagnose it. So this patient underwent a PI, and after that you can see the flattening of the iris contour there. So it helps you to understand what is happening under the iris in certain conditions. Again, this is Peters anomaly. It looks, everybody knows what this condition is, but whether there are just iridocorneal adhesions, iridocorneal lenticular adhesions is something that is very important for us, so that it helps you to prognosticate as well as plan your surgery. Primary congenital aphakia, again we know it's a clinical diagnosis. If any of us have seen this case once, I don't think we will ever miss it. We know how the corneas look pearly white, and these eyes are usually small, axon lengths are very small. If the eye is larger in size, if there is an asymmetry in the size, then you know you're dealing with glaucoma here. And B-scan, of course, you will not be able to see a lens placode, but the UBM helps you to understand as well the anterior insertion of the iris ciliary body as well as the absence of the lens in its position. So this is again very important. Sometimes clinically these conditions are quite obvious. Nobody need to tell you what this condition is. But what UBM helps you to understand is what is the relationship between the iris and the cornea. Is there a Descemet's detachment that you are dealing with? Is there an iridocorneal adhesion? How extensive it is? That will help you to plan what type of surgery one needs to do. So this, I don't want to go into the details. Faisal again showed this. It also helps you to make surgical decisions. What type of surgery would work in certain patients. So this is again something that he alluded to. She's article very beautifully showed this, based on the severity of trabecular dysgenesis, how the angle-based surgery would help. So this is something that's very important. In a severe dysgenetic angle, maybe one need to go in for a filtration surgery rather than doing an angle surgery. Ciliary body cysts and tumors is something that we have to be worried about as well. Sometimes they can present as congenital glaucoma also. So that's why it is a routine for us to do a B-scan for every child who presents with congenital glaucoma. Even if the cornea is not so hazy, we will not be able to make a complete posterior segment assessment. So B-scan becomes very important. This was a young girl again presented with neovascular glaucoma unilateral fundus. Obviously we couldn't see anything abnormal. UBM showed a tumor. Okay, so this child had a medulloepithelioma that had to be treated. Also helps you to follow up. Once treated, the tumor just melted, and this child had useful vision, and we had to take care of the intraocular pressures as well. Of course, there are limitations. We need to understand that anything that is deeper than 4 mm, we will not be able to get it. You need to do a proper evaluation. You need an experienced operator to do this. We have to be very, very careful in doing UBM in a child, especially when the child is uncooperative. You may hurt the eye. So to conclude, I would say UBM is very, very important and definitely plays an adjunctive role in establishing the diagnosis in patients with cloudy corneas, not just in cloudy corneas, also in those with clear corneas, where you will be able to make a proper diagnosis as well as follow them up once the evaluation is done and after an intervention is done. Also sometimes helps you to, let's say for a spirophakia, once you know what the condition is, or an aniridia, you will be able to do a systemic evaluation and possibly help the child in multiple other ways as well, and prognosticate and help the patients. Thank you so much for your patient hearing.
Thank you so much, Dr. Sirisha, for putting that up together. And I think the next what I'll do is I'll just present some cases, and I'll be happy to have the audience interact with what they think. So. Right, so once we have this and we've learned to do that and to correlate, it's important that, what are we doing in everyday practice. So all these children, their parents have given consent for us to use their pictures to learn and to help us learn as well. We don't know what we see, I love this, but we see what we know. So once we know what we're looking for in the next baby, we are going to see it. So we started off like that, and it's a complete unknown ocean, and now there's some semblance of learning through these years, and we are constantly learning. So these are just some snapshots to show you the utility of the UBM and why we are all such fans of this. This is actually presented to us with primary angle closure for LI, and turned out to have just a high insertion on JOAG, and you see where the iris is inserted high up. So it's very easy to go wrong sometimes. This was somebody who came with trauma, with persistent endophthalmitis despite surgery, and finally when the pressures rose and was referred to the glaucoma department, something told us that there's something going on the gonioscopy. So it's just the clinical thing which makes you think about it, and it turned out that there was just this little piece of iron which was embedded in the iris, and I can assure you there's nothing else on earth which could have picked this up, and it was easy to just snip the iris away and take this out, and that's what was a better management. This of course is the garden variety of pigmentary glaucoma with a concave iris, which is seen very well on the UBM. And his pressures were very high, and he was intolerant to drugs. So when we did the LI, actually it helped. It doesn't help all, but sometimes you could see the effect of LI as well. This is something that we see. This is a plateau iris, and you can see that if you don't recognize a plateau iris, sometimes there's no effect of laser. And these pictures show us how the laser iridotomy, if you do it peripherally, the ciliary body is just sitting on the iris and pushing it up. So it's not going to work. And the UBM helped us diagnose the condition, and then we went on to do the iridoplasty, which is thermal burns at the base of the root of the iris. So this is just a snapshot of what all the UBM can teach us, and that's when we went on to the children. So there's no financial interest, but yes, there are lots of 35 megahertz UBMs going around. Now, this is a resolution with a 50 megahertz. You can see the iris cyst, you can see in a young boy a topiramate-induced angle closure, and these are the resolution with a 35 megahertz probe. So when you're trying to really make a decision of anterior segment and make a decision of management, I think it's well worth investing in a 50 megahertz probe rather than a 35 megahertz. And I can tell you a lot of the machines have 35/50, so it's important to do it on a patient, see it, and ask the company to show 50 megahertz images before you buy it. So this is a picture that Faisal also showed, which was actually on the cover of the journal, because it taught us so much about neonatal onset rubella presenting with congenital glaucoma, which we don't think of. Neonatal onset rubella, we think it is cataract and salt and pepper retinopathy. But we were surprised at how many of them turned out to be rubella positive. So we've already said this, we've no idea what is behind. Now, this baby, for instance, it makes me a little okay about operating this neonate, because the only thing that is there is a really thick cornea, and probably with a combined trab with trab, he's going to be all right. And post-surgery, as the child grows, most of the cornea has cleared except a central bit which is scarred, which you can probably get away with just doing an optical iridectomy, and you can see how the cornea has reduced and the thickness has reduced once the pressures have come down. But all white corneas are not always primary congenital glaucoma. So we've seen a lot of Peters abnormalities. These are large Descemet's defects on both eyes, but the clinical clue is that little bit of central clearing in the cornea, which would make you look for a Descemet's defect on the UBM. But it's not always only a Descemet's defect. So this 3-day-old baby, and the left cornea is a little clearing in the center, but there's something that tells you that something is wrong, and it's looking a little cystic, in fact. So what this baby had was what we now call it a large corneal cleft. For lack of how to describe this, we started calling these corneal clefts. So you have these huge clefts within the cornea, And if you do the pachymetry, the cornea is very thin. That's because the pachymeter only checks the initial. So initially we were very worried before having the UBM that how come this is just a 200 micron cornea or 150 micron cornea. But that's because there's this huge fluid pocket, and before we had the UBM we didn't even know what this was. So this is a large Descemet's defect with a large cleft, as we call it. And post-op, again, the cornea, the central, because it's a Descemet defect, it scars. But if you can manage to clear the periphery, we do manage to do an optical iridectomy while the baby is waiting for an OPK. And actually, this eye actually has 660 vision. Of course, had PCG in the other eye, which cleared completely. So these phenotypes overlap. You can have Axenfeld in one eye and Peters in the other with the same genetic mutation, because each one of them is interrelated. They regulate each other. So the phenotypes might be different in two eyes of the same baby. Now, even if it's the same disease, it could be very, very asymmetric. And that's where the UBM helps. So you can see there are Descemet's defect and there are corneal clefts in both eyes. But if I have to tell a corneal surgeon, I have to push him to do a PK, I'll tell him to do the right eye, because the anterior segment disorganization is less, and it helps right at the beginning to prognosticate. Now already if you have a flat AC and the iris stuck in the cornea, this is going to be a far more complex anterior segment, disorganized anterior segment, which needs to be treated right. So I would go for the right eye and maybe masterly inactivity in the left, unless they have to. Then the defect in Peters could be very, very large. So this looked very funny. I mean, this looked like a little balloon, and of course just primary congenital glaucoma in the other eye. And this Descemet's defect is so large that with the high pressure, the crystalline lens has gone and stuck in the lens itself. So no matter what you do, you know at the back of your mind that you'll be able to do something about the left eye, but the right eye probably is already gone. And though we did surgery and we it's not going forward. Okay. Anyway, so how does it matter? I had pictures of the post-op I would show you. All right. So if we see a cataract with glaucoma, that's the first thing. Think of rubella. And why that's important is, and sometimes like this baby, you can actually see that whitish thing beneath it, and it's seen better under the microscope. So this is in the OR under GA. So if you see it, it's not important that it's just a cataract and might be rubella. It's important because there are three systems involved: the eye, the heart, the ear. And there are many who we used to send, and now we understand that. We've sent for developmental delay. They're not developmentally delayed. They can't hear. So all they required was an ENT referral, and the BERA would show up as very, very diminished responses, and all the children needed was a hearing aid. And once they had the hearing aid in place, their world just opened up, and suddenly a developmentally delayed child was much more better, much more normal. So it's not just ophthalmology. It is possible to change what you're doing for the baby, because that baby you want to be as productive as individual for society as possible. So this, of course, was the UBM which taught us this, and it's the UBM which taught us that so many of them could have cataract. The other condition, of course, would be oculocerebral syndrome of Loewy, but that's completely different. You have sunken eyes, you know, the picture of a Loewy syndrome would be completely different, but rubella in our country with non-universal vaccination is a reality. So, of course, okay, so here it is, going back to the same baby. He landed up with an unsightly blind eye, though the left eye cleared completely as we thought it would, and this was the defect. So you need to know that your babies have a life, and we advised the parents to go in for an ocular prosthesis, because we didn't think that with this level of amblyopia and this level of disorganization with the lens there, this baby was not going to have too much vision, which was improving. And now he's grown up and he's actually enrolled into school. So you partner with them and you be one with the family, and you realize that sometimes you have to, with a heavy heart, know that there is only so much you can do, but there's more to the child than just the eye. And sometimes, again, we've started noticing these bad staphylomas. They come in the neonatal period, and what we started doing is doing the torch evaluations, and a lot of them actually have vaginal infections. So these are probably intrauterine perforations, which happened in utero, and the mothers have been treated for chlamydia later. So this is something which we've seen lots and lots of strands going and converging at one point, which probably in utero itself has formed a staphyloma and come in front. So there are things that there's not much you can do about this, but at least you can tell the parent, and if nothing else, send the mother for a gynae evaluation. So when I have something like this, I tell the mother to go for a gynecological examination, and I'm amazed at how much of chlamydia urethritis there is that we don't even know about and we don't talk about. So this is not an IUGR, this is a secondary thing, I suppose, because there's nothing in the baby except this ocular abnormality. So sometimes you need to make these difficult decisions when you have this young girl with UBMs like this. So I wouldn't be too much in a hurry to touch the left eye. I presume she would be pretty much amblyopic with a long-standing, there's a cataract, there are iridocorneal strands and everything, but the right, on the other hand, looks relatively better. And with the optical iridectomy, she's going to school now with reasonable vision. We're not so fortunate with having a robust pediatric cornea service, which is difficult, but it's not fair to give up on the babies just because the corneas are not available or we have constraints. So we do these optical iridectomies while we are waiting for them. On the other hand, if you have intractable glaucoma with a persistent corneal scar after a combined trab with trab and your UBM looks like this, then you really push them, and these babies do well with a corneal transplant. So know what you push for. In a constrained resources, it's important to pick the children and then send, rather than close your eyes and say refer to the cornea clinic, because there are some which you know are not going to do well regardless. But we push some of the ones where the anterior chamber is nice, and we tell them that these are people who probably the children would do well. Sometimes the OPK fails, and even in a failed graft where they are referred from the cornea clinic sometimes to do a UBM and for them to figure out which would be a better. So she doesn't have glaucoma, but she's a failed graft from the cornea department, and you do the UBM and you realize that again the right has extensive anterior synecdoche of the iris, it has a cataractous lens also. I would say let this be and concentrate on the left eye, take the cataract out, reconstruct the anterior segment, and the left probably has a better chance for survival than the right one. So making decisions for these children sometimes gets to be very useful. Then, of course, Dr. Sirisha Faisal has talked about the congenital primary aphakia, both of them. So this is the silvery blue hue. Whether it's in Hyderabad or in Chandigarh, they look the same. We've learned to recognize them, and the UBM, of course, shows very thin cornea, which is dysgenetic, and no lens. And believe you me, you should let them be, because they are very unpredictable after surgery. So I'll just take you through a valuable lesson learned. Interesting, we learn every day. So this baby came to us with the history of trauma, and there was this worm-like thing, and the mother was distraught ki keeda ghus gaya. So, there's a worm in the eye, and there was hyphema. So this was funny because the other eye looked completely normal, and we said, okay, let's take it up. And for some reason, I said, let me look beneath the iris and let me see what's there. So we did the UBM. So this is what it looked like. You can see the hyphema, you can see that little worm-like structure. And this is under the microscope, and there was a little bit of corneal diameter was all right, 12.5. The pressures were a little high, 18 in one eye, and the other eye showed multiple strands actually. So it's the phenotyping which is important. Now, the gonioscopy of the left eye, the right eye I didn't see too much, but the gonioscopy of the left eye showed these characteristic anterior iris processes, and we call them Y-shaped processes because they go up and then they sort of get out into Ys, and that's our sort of eureka moment of Axenfeld Reigers. And we said, my God, this is what we're dealing with, and is that a detached Schwab's line? And then we said, okay, let's do the UBM and see, and sure enough, you can see this iris was pulled over a normal looking pupil by a Schwab's which had detached and had caused a hyphema. So the UBM really told us that, look, all we need to do is probably cut off this redundant iris which has come on top of this. So we used a vitrectomy cutter, and we did a pupilloplasty sort of thing. So we really were fishing through waters which were largely unknown, but we probably had a bit of an inkling. So we took that little bit of hole that was there. So you can see that is the Schwab base, which has completely detached, and we inserted the cannula in that hole because we knew now with the UBM that the lens is probably clear and the pupil is normal, and we wanted to be sure that we are not going to cut the lens. And once we ballooned up the iris, slowly with a very, very slow vitrectomy cut rate, you can almost see, you can count the cut rates, and you can see slowly the pupil is coming into. So this was just an iris fold which was over the pupil, and we just cut away that fold which was there, and this is an absolutely normal pupil underneath with the sphincter intact. So next morning, to our delight, this is what the eye looked like. So we were so happy, and everybody was so happy looking at him, that look, this is what the UBM did for us. So sometimes you learn, and then we examined the mother, and she had an Axenfeld anomaly, but normal pressures, normal discs, but an Axenfeld anomaly nevertheless. So then we are going to look at doing the genetics for them. And we thought it was fine, and this guy is now 4 years old. Now you can see the hypodontia, because he was such a small baby we couldn't make out at that time. There's hypodontia, there's a flat nasal bridge. You can see the iris processes now, and you can see the discs. So now everything fell into place, and we realized we were dealing with Axenfeld rigor. And while we were patting our backs, we had another baby with a complete achoria. And here were the iris processes, not as robust as the other one, but we thought, okay, let's go ahead and look at the UBM. It really shows that this iris is now adherent to the lens. So this is something to be very, very careful of. So we decided to do a pupilloplasty, but maybe in one side, because we didn't want to touch this this part of the iris, and we thought if we can just cut this and make the iris go down, maybe we could salvage the lens or protect the lens, and maybe do a pupilloplasty if we could. So anyway, we tried that. We went right in, and what we planned was to do it inferiorly so that we don't touch the central part of the lens. And what we did was made a certain eccentric sort of pupil. At least the axis was clear for some days, but alas, it didn't last long. And as expected, this lens did opacify. So she underwent cataract surgery with an IOL, and now at least with extensive patching, there is some ambulatory vision as well. But, and then we had another one. So sometimes they do come in crops. So this we learned our lesson better. And again, attaching to the lens, again the same iris processes, other eye normal, which underwent a goniotomy. So this time we were more careful. We went even more peripherally. And now this baby is about 3 years old. I'm very wary of touching the clear lenses of these children. So this is something which we always keep in mind. But with the patching, she's 2 years later, she's 6'12", and the left eye also has undergone a goniotomy. So sometimes it's just that knowing what it is helps you plan your procedure and plan what you think would be best for the babies. I'm not saying that they'll all be fine forever. We'll keep them under follow-up, but at least we do the best. So this was our learning point with Axenfeld, all learnt by using the UBM in the OR at the time of an EUA. They are all not developmental glaucomas. This one has been was referred to us with PCG, but on asking a history, the mother said it's a fingernail injury, after which there was a lot of redness and watering, and then it subsided. So sure enough, there you can see a full thickness corneal scar with the Descemet's membrane intact, but the pressures were okay. So we sent this to the cornea department because there was no glaucoma in her. Just as a parting shot, this is a child with silicone oil, and this actually is the silicone oil there, and this illustrates beautifully what we know. So the convection current of emulsified oil going into the angle and telling us why there is glaucoma in emulsified silicone oil. So To summarize, imaging the angle and anterior chamber has changed the management, and more rational, more informed choices of management are possible. But then we use technology as an ally, not as the master, and we can't use it in isolation. Thank you. So I'd be very happy to have some audience interactions. Any experiences which any of you might have? We do have a keynote of Dr. Mohammad Shamsi is here, I think. Yeah. So we have time till 10:25. So probably we could have 5 or 10 minutes of an audience interaction. Then I'll invite Dr. Shams for his lecture on congenital glaucoma. He has a 10-minute keynote. Sirisha, any comments about how it is used? What else? Any tips?
So wonderful cases, and thanks for highlighting them so beautifully. Yeah, so it is definitely very, very useful. So many times this is a question that is asked, can we do a UBM in the clinic, and necessarily should we do it under examination under anesthesia? Not necessary. In fact, many of these children, you can pacify them, especially when they are sleepy. We can use, we don't use speculum. We take the mother's help to open the lids, because sometimes the minute you put speculum, they can be squeezing and screaming. So with the help of just separating the eyelids, of course we use the automated water bath that is available, the disposable one, and we should be able to get those images. So even if you get 1 or 2 clear images, we should be able to understand what the condition is. Otherwise, many times it's like cornea/glaucoma EUA. You don't know what it is, whether the baby is going to require a surgery, a short anesthesia, long anesthesia, minor OR, major OR. These are issues because they're coming from far away and you need to make a major decision. So we can do it even without anesthesia, with a little bit of restraint, but we should be able to help make a decision at least.
I think it's possible in either the very small baby or the child who is about 5 years old who listen to you. It's the 2-year-olds and 1-year-olds which really require, which I have seen require GA. Those terrible 2s are the ones which you can't restrain no matter what. Yeah, Sushma,
so that
please.
one case I had a comment, that was persistent pupillary membrane with detached valves line. So the pupilloplasty that you did. So this is exactly the picture that I had shown to a child with bilateral So when you say persistent pupillary membrane, to me I used to think it is that white lacy membrane that you see. Not necessarily. You can have patch of iris tissue sitting there that can actually block the pupil. You can have secondary glaucoma, or they can have one small eccentric pupil that is still functioning, which means there is no pupillary block in that area. So it's very important to diagnose. So achoria, absence of pupil, displaced pupil, multiple diagnoses we have given. In fact, there is a case series that we have published not knowing what it was. We just created a pupil in all of these patients because they were secondary glaucomas, but then now you understand. So you always have to examine the contralateral eye, because you may have subtle findings of axonal rigor, and you beautifully showed even examining the parents to be able to get a proper diagnosis.
Well, thank you for the very interesting cases and very knowledgeable IC. I really enjoyed. So just wanted to add that part that I think the perichloral or the nasal drop sedation is also something that helps even in the children who are like not very aggressive kinds, and even 2 or 3 years old. We are mostly able to do most of the stuff before we take them to the OR. So yeah, UBM may be the only thing that may be remaining in these patients, but a lot of even less than 1-year-olds and all, UBM is possible thanks to those disposable probes that we have these days with the balloon stuff, and you really don't need speculums and cups. So very, very useful even before we decide about how much GA, how much surgery and stuff.
Thank you. And in fact, just a comment that nowadays we've even started using the AIOC2022. So there's something called a flying baby technique, which we do, which my current partner in crime is Ashok, so he's the one who does them. So you just hold the baby, as Kendishtil said, flying baby, put in a speculum. They cry a bit, but sometimes you can avoid the UBM and get quite good images, especially even in mildly hazy corneas, you get some idea in the clinic. But since we have the luxury of the UBM in the OR and we are going to take them up for UA, we don't try to do anything in the clinic. We just do it at the time of the UA. It's become part and parcel of our. But of course, if you don't have a UBM in the OT, then of course in the clinic we used to do that initially. Yeah. Yeah, please.
Thank you very much for this nice talk. My question just to Dr. Sushmita and Dr. Sirisha. So now it should be considered as a role for all cases with congenital glaucoma and corneal opacity to do UBM. And it's a common practice in your clinic to do UBM for all patients with corneal opacity?
Yes, that's what I said. Because I have the luxury of the UBM in the OT, so since all of them are going to be taken up for UA and surgery anyway, so UBM is part of our UA, our routine practice. Unless I can do a gonioscopy, see the angle and make a diagnosis. If I can't, then I would use the UBM for everything. Yeah. Sirisha, what about you? I think he asked you as well. Would you do it for every child with a corneal opacity?
I don't have UBM in the OR, so we have it in the clinic, so that's the reason why I think we try and innovate and do that in the clinic even before you take it up. But intraoperative OCT, the anterior segment OCT, the handheld one is something that we have which is mobile. But the only issue is that you need to have somebody who's well trained to be able to do that.
And I think reasonable corneas. I don't think you can do much, even in completely opaque ones.
Not completely opaque ones. Majority of the time, even in the corneas with grade 4 corneal edema, we still will be able to get the images.
Right.
If I may say something, I think we don't have UBM in OT, but we shift our OPD UBM to OT. That is also quite possible. We have a trolley. We have a UBM on a trolley in the OPD. So whenever there is a UA, we shift the same UBM machine up. Yeah. So just wanted to say that is possible. That's what we follow.
But it has also complications of sister indent and then sister indent out again. So lots of those issues are there. Yes. So we don't do that. Right, I think we can go on to Dr. Shams, please. We'd like to listen to your talk on congenital glaucoma. And I'm sorry they haven't given me your introduction, so please introduce yourself as well. Thank you.
Good morning. I've been here for the last 45 minutes, and everything what I knew on UVM in congenital glaucoma, childhood glaucoma, that was really ocean of knowledge. I gathered a lot, and now my presentation is quite different from such an UVM and investigations procedure. And this is all about the congenital glaucoma, my little experience in my country. So lovely child with painful blind eye. So this is a lightning and thunderstorm in a clear sky, hopeless condition to appearance. Then what next? What to do? We must care the patient. We have to make a plan. We have to take action in time. Congenital glaucoma, how far we have come. I am Dr. Shams Mohammad Noman, Associate Professor, Bangabandhu Sheikh Mujib Medical University, Bangladesh. This is the only medical university which controls all the post-graduation degrees in Bangladesh. I don't have any financial interest doing this presentation. Our challenges in my country. Poor socio-economy is a great challenge. Consanguineal marriage, you know, the congenital glaucoma is 4 times higher due to consanguineal marriage. Lack of knowledge about the glaucoma in the periphery. Excitement over large, beautiful eyes. Some parents are very much excited seeing the large eye in his child. So they think that it's a very good, this is the beauty of his or her child. Fear of surgery. Lack of expert surgeon in different areas of Bangladesh, because we have lack of glaucoma surgeon, but also, and it is really very challenging to find out a childhood glaucoma surgeon in different areas in Bangladesh, lack of physicians' interest. And the reward is not very much good, so very few surgeons used to do this surgery. I'm telling about the reality actually. General anesthesia. It's really a challenge in different peripheral areas of our country. A special instrument is needed. This is also a challenge. What are the other challenges? Congenital glaucoma and childhood glaucoma may be associated with the other ocular associations like aniridia, Sturge-Weber syndrome, Neves-Sobota, Axenfeld-Rieger syndrome, Marfan syndrome, Murchison syndrome, and Down syndrome. We do examination under anesthesia, external exam, corneal assessment, refraction, ophthalmoscopy, exam under microscope, tonometry, gonioscopy, and ultrasonography. This is the basic thing we all know. Corneal assessment, we do the horizontal corneal diameter, we try to find out the habestra, corneal edema, corneal scar. We do the Parkin's tonometry of those patients to see the intraocular pressure. A gonioscopy, we do the surgical gonioscopy with Swan-Jacob and Mori gonio lens. This is one of my patients presented with phacomatosis pigmentovascularis. It's a very rare congenital systemic disorder. Patient has a vascular anomaly all over the body and unilateral corneal edema. And if you will see, there is a large cornea, corneal edema, thin sclera. I used to give a triangular incision, triangular flap. Patient was also associated with nevus of aorta, very thin sclera. Now I am doing the trabeculotomy, the most important part, with the Herm's trabeculotomy. Sometimes it is very much challenging because it may touch the iris tissues, and as everything is very much vascular, the possibility of bleeding and intraoperative hypoma possibility is more, and ultimately we finish the surgery with a great success. This is another case of very complicated glaucoma patient. Underwent cataract surgery followed by raised intraocular pressure. I did the tube implantation in such case, amid volume implantation. So sometimes it is very important to see the depth of the anterior chamber and also the thickness of the sclera. I am just covering the tube with the tutoplast. I like this. This is another case. I am doing the trabeculotomy. Doing the D block excision with Kelly punch forceps. Now I'm sometimes I used to implant allogen in case of congenital glaucoma. So this is one case where the patient is presented with very enlarged cornea, and the second one is third postoperative day, and right downwards is the left downwards is the seventh postoperative day. So different surgical treatment, goniotomy, trabeculotomy, 360-degree trabeculotomy, trabeculectomy, combined trab and tram, drainage implant surgery, cyclodestructive procedure. In my country, we used to do the trabeculectomy, combined trab and trab, drainage implant, and sometimes you do the cyclodestructive procedure with cyclodiode. This is the most preferred technique so far. In my experience, the success rate is 80 to 90%. But the most important thing is to rehabilitate visually. Correction of refractive error is a challenge. Correction of media opacity, the corneal scar and cataract, orthoptic treatment and amblyopia therapy. Parents counseling is very much important because their help is very much very important to ultimately settle the patient, and it will relieve the anxiety and improve the compliance. This is some of our leaflet which we have produced in our institution for giving to the patient. I think I am recommending every institution to do that. It will really helpful. It contains something about the congenital glaucoma. It should be in the local language, and also different treatment options. Though these are some child's postoperative cases. I used to very much happy to see those smiles. Thank you everybody for your patient hearing. Thank you.
Thank you so much, Dr. Shams. Since we have 5 minutes, Dr. Shams, can we take a couple of questions if anybody has? So session ends in 10 minutes. We have 10 minutes for a discussion, for an interaction. So Dr. Shams, are all your children usually scarred and opaque corneas? Are you thinking of the not so opaque, doing angle surgery in them to try and avoid the conjunctival?
My experience in our country, if it is okay, if I see this intraocular pressure is not too much high, cornea is enlarging, I used to do the B scan if everything is fine. Sometimes I wait and I don't do the surgery. Okay. I don't do the surgery, but most important challenge is examination under anesthesia, because I don't have any facility to do the UBM in our country. Actually, in the premises where I works, but when I see that the cornea is becoming opaque and patient has some problem, and also some photophobia and blepharospasm, and that time I used to do the examination and anesthesia if the intraocular pressure is raised, and also if I used to see the optic disc, the disc is getting larger, curved disc ratio is getting larger. In that cases, I take the decision for the operation, angle surgery.
For angle surgery
yes.
as well. And since you said, just one question about consanguinity, since you said there's so much of consanguineous marriages,
yes.
and it's likely to have homozygous disease, which is more severe, would you do any parental counseling and would they listen? I mean, is it possible that, because that's something tricky that we're also facing, but though our part of the country, we don't have consanguineous marriages so much. But do they listen? I mean, is parental counseling a part of it now?
Yes. Yes, because when we celebrate the World Glaucoma Day, in different TV talk shows and also in our different forums, it is our common talk that the consanguineal marriage is a very much risk factor for developing of congenital glaucoma. And also in our office, when the patient comes with a baby large cornea, the baby referred to us for a congenital glaucoma. This is our first questions about their marriage. And also we used to just circulate it in different areas. And also in different institutions, we have some videos about very awareness videos about some congenital glaucomas, and it is running in different patient areas. And some advices. So consanguineal marriage not to do the consanguineal marriage, not to choose such a couple, such a planning. It is a routine counseling.
Yeah, so that's important that you
Yes,
already,
yes.
I guess when they have a baby, probably it's easier to tell them that once you have this,
Yes.
your likelihood is more or something else.
Yes.
Because now genetics, at least in India, is getting to be a little more
Yes,
affordable.
yes, yes.
So we have more evidence
Yes.
to tell them.
Yes.
Well,
I have one question.
Yes.
That is the in up to which age, at which age group you refer the patient for the keratoplasty?
so if I think the child, see, there's no point in waiting, because if the cornea is opaque, then we lose the chance of vision. So Sirisha is fortunate to have a very robust pediatric cornea service.
Yes.
Most of us don't. But I would want them to do it as early as possible. And
Okay.
like we do the glaucoma as early as possible. Having an opaque cornea in the formative first year of life is not going to do very much if you're going to wait till they're a year old and then do it later.
Yes, yes.
That's my take on it.
Dr. Shirisha, what is your
Yeah,
experience?
so I agree with Sushmita that we have to be very wise in advising who requires a
Yes.
keratoplasty and who would benefit from it. So if the cause is the corneal problem and there is a corneal opacity, especially bilateral, and the child is developing a nystagmus, then that means the baby requires a keratoplasty. There's no point in waiting. So we do it, in fact our corneal surgeons do it as early as 2nd or 3rd month in life. So as early as that, very, very young babies, but the evaluation and follow-up is extremely important. And before we embark on doing a corneal procedure, the parents are actually evaluated and made sure that they agree that they will come back for a follow-up. Very, very important, wherever
Right.
they are from. They could be
Yes.
from Gujarat, they could be from, Jammu
Bangladesh.
Kashmir, wherever it is, Bangladesh, wherever it is. In fact, we have children coming from Bangladesh. We tell them, so they take an apartment and they stay here for 2-3 months. Fix everything. Once all the sutures are out, cornea is clear, then you discharge them. So it is very, very important. And because on a weekly basis, when the sutures get loose, we need to keep removing them, make sure, because infiltration and infection is the two major problem apart from glaucoma. So that's very important, number one. Number two, the kind of cases that Sushmita was showing, the Peters anomaly. So the eyes that have relatively clear cornea, when we do a glaucoma surgery, they clear. The contralateral eyes, which also have a lenticular corneal adhesions, there is a procedure, which multiple procedures are there, but of late people are talking about lensectomy or a CPAS, where you leave behind a little bit of the attached lens capsule to the posterior corneal defect. And these corneas, what is so interesting is that once you remove the lens attachment to the cornea, cornea automatically clears. In fact, when people told me, the corneal people told me, I never thought that it can actually clear without a keratoplasty. But once they remove that adhesion, be it a complete lensectomy or leave behind that capsule and remove the rest of the lens, the cornea completely clears. Maybe a faint scar, but it clears. So to a great extent, we should be able to save these eyes. But yes, we need to do that at an early stage.
So the hypothesis that they say is that there is abnormal endothelium in the area of the defect. And if that is somehow removed, and the normal endothelium then sort of grows over and clears it. But
So you are just remove that membrane. This is the peeling of the membrane, or like just to cut the membrane?
Cut it. You don't
Okay.
pull it. If you avulse it, the rest of the desmids also can get detached.
Okay, okay.
And even while doing the pupilloplasty, while we have to be extremely careful about not touching the lens,
Yes.
same way with the decimate. So when you're making your first entry with your paracentesis, when trying to get a cleavage plane before you inject the viscoelastic, you should be very, very careful, because I have seen a couple of cases where the desmids completely gets detached, and then you're so comfortable you go and remove
desmids
everything,
along with
including the desmids. So these eyes are very tricky, very tricky. So you have to be careful, especially if it is completely stuck to the cornea.
And very interesting, we are facing another challenge in our country. When we have counseled the patient for the surgery, and the people used to take time, because a very small child will undergo surgery. So within this time, we put drops, and very interesting, 15 or 20 days patient get better. And for this, patient don't come to our, don't come back. And this is really a great challenge. Okay, patient is responds with medications, so I think he is getting well.
I think first visit to try and tell them that, that they will 100% require a surgery.
Yes.
And whatever these medications are only an interim, very, very important. Otherwise, I totally agree with you. Many times they say the cornea is cleared and why should you come back? And many times you hear the referral doctors who say, let the baby become a little older.
Yes.
You can do the surgery later.
Very
or
common,
the grandmother
very
tells risk of loss of life when you do a surgery at an early age. All sorts of funny things you hear. But I think it's spending that extra 5 minutes to speak to the parents that this is a lifelong problem and we need to, the earlier we treat, the better it is. So I think a lot depends on the counseling.
Thank you.
Sure. The last, and then we'll hand over to the next IC.
Thank you very much. Actually, I have seen one of your cases during trabeculotomy, bleeding was there, so you put air bubble. In my practice, I feel that during, trabeculotomy, sometimes, especially in large corneas or in older children, more than 2 years, I find, bleeding, starting. So, is there any tips or tricks to avoid this bleeding? Because actually it is noising during surgery. That is for all of you. If you can
I think the one he showed with bleeding was with the nevus of aorta in the
It's a vascular.
So there, no matter what you do, the minute you're going to cut that sclera, it's going to bleed. So I think you just need to. So one thing that I do is I have a little bit of adrenaline-soaked sponges.
Yes.
So before if you try to cauterize all that abnormal vasculature, nothing's going to happen. Just the sclera. So I just press on it for some time, especially in Sturge-Weber or Klippel-Trenaue or even pigmentovascularis, and then it sort of subsides, and then you do the cautery to the bleeders. That's my take on that.
It's not, during trabeculotomy, when you go inside by sure. When you go inside or trabeculotomy, so for small children, months children, I didn't face bleeding, but for large corneas, maybe, I don't know, maybe the sclera become a little bit behind or something. Or for older children also.
Okay.
During trabeculotomy, once I start trabeculotomy, then what I do, just cauterization, the opening of the thera, but sometimes works, sometimes not.
Maybe there's a little bit of an iridodylisis at that time, possible.
Probably due to thin sclera, sometimes it is very, it is really challenging to diagnose whether it is the iris and ciliary body. When we touch the ciliary body, we may cut the ciliary body. In that case, extreme hemorrhage can be occurred. So, Madam, what's your experience?
I think Sushma has a
we are
comment.
running out of time.
Yeah, we're running out
so
of
maybe
time.
we can discuss out of the session.
Yeah, Sushma, just the last point and then we'll hand over.
I just wanted to ask, what I use is for the surface bleeding, a drop of alpha-GAN. Since the child is under GA, you can monitor the heart rate. That helps in reducing the bleeding at the time of sclera. So a drop of alpha-GAN is what I use.
Thank you. Thank you everybody for this great discussion and great time on childhood glaucoma. Thank you, Dr. Shams, for sharing.
Thank you so much.